Yeah. I am Dr. Abhilash. I am a third year resident from Yashoda Hospital, Somajigoda, in Radiation Oncology Department. And today I will be presenting a case about an carcinoma breast. First of all, thank you, Kanu sir, for giving us this opportunity before the exam. It's really, really helpful. And I'm feeling honored to present under Senapati sir right now. So I will go ahead with my presentation. So my patient is Mrs. Agarwal, 50 years old, postmenopausal lady, housewife. She is from Hyderabad and she presented to us with the chief complaints of left upper breast lump for the last 5 months. My patient was apparently normal 5 months ago when she first noticed a small lump in her upper quadrant of the left breast while taking shower. The lump was initially around 1 centimeter size. The patient has described as an small peanut or marble, which has gradually and progressively increased in the current size, that is 2 to 3 centimeters, according to the patient. The lump has remained painless throughout this 5 months, and there is no history of any sudden enlargement or fluctuation or regression in the shape or the size of the mass. There is no history of any trauma, infection, or recent lactation. There is no history of any cyclical pain, fever. There is no history of any skin ulceration, nodules over the lump, or any nipple discharge. There is no asymmetry between the two breasts, and there is no complaint of any fullness or swelling in the axilla as well. There is no supraclavicular swelling. There is no skin changes in the ipsilateral upper limb. There is no restriction of arm movement, tingling, numbness in the upper limb. Patient also does not have any complaint of any backache or any bone pain. Uh, there is no history of any abdominal pain, distension, or jaundice. Patient does not have any complaint of any cough, breathlessness, chest pain, or hemoptysis. The patient does not have any complaint of any loss of appetite, significant loss of weight, easy fatigability, or any night sweats. Patient did not complain of any headache, vomiting, or convulsions at the same time. Now, coming to uh, slides are not moving. 1 minute.
Nothing to worry. If it is not moving again, okay, okay, it started moving.
Okay, sir. Okay. So again, I will just after the now I'll come to the menstrual history of my patient. She has attained menarche at the age of 13 years. Her cycles were regular every 28 days and lasted for 4 to 5 days with moderate flow, no dysmenorrhea, or no cyclical breast pain. She has attained menopause last 10 years ago. So at the age of 40 years, patient does not complain of any hormone replacement therapy in this time period. Coming to obstetric history, age of her first childbirth was at the age of 21 years and age of the last pregnancy was 25 years. She has three living children, all delivered by normal vaginal delivery. She is para 3 and L3. There is no history of any abortion. She has breastfed the first child for 8 months and the second and the third child for 1 year. There is no history of any OC pill intake in this period. Coming to the family history, there is a significant family history because her mother got diagnosed with breast cancer at the age of 48 years and then expired at 49. Upon asking, the patient told that she was diagnosed with cancer but has not received any treatment in that period and she expired due to cardiac causes at 49 years of age. And patient was then asked about ovarian carcinoma in any of the first degree or second degree relatives, which patient denied. And patient also says that there is no history of any prostate, pancreatic, or colorectal cancers. No history of any male breast cancer, multiple primary cancers, or any early onset malignancies in the family. Now, coming to the past medical history, there is no history of any comorbidities. There is, as well as there is no history of any major surgeries. Only tubal ligation was done for the patient post third delivery. Personal and socioeconomic history: she consumes a mixed diet. She has normal appetite. Her bowel and bladder functions are within normal limit. Her sleep is adequate, and she denies any history of high risk sexual behavior. Sir, should I jump to clinical examination?
Yeah, go ahead.
Okay. Uh, Coming to clinical examination, first patient was explained about the procedure of clinical examination, and then informed consent was taken. Then patient was taken to an well lit aerated room, and she was examined in presence of a female attendant. Coming to the general physical examination, the patient is conscious and oriented to time, place, and person. Her ECOG performance status is 1. She is moderately built and well nourished. Her height and weight are 152 centimeters and 63. Her BMI is coming around 27.3, which is in the overweight region. There is no history of any pallor, icterus, cyanosis, clubbing, and pedal edema. Supraclavicular, all the lymph nodal chains were examined, and there was no significant or generalized lymphadenopathy seen. Coming to the vital signs, all the vitals were within normal limits. Now coming to the local examination, again before local examination, patient was explained about all the positions she need to follow, and all demonstrations were given once. Then in presence of a female attendant, the examination was done. The positions that patient was examined on includes sitting with arms resting by the side of the body, semi-recumbent position at 45 degrees, with hands pressing against the hips, then with hands raised above the head, and with hands pressing against examiner's shoulders and leaning forward. Now coming to the inspection of the breasts. In inspection, both the breasts were symmetrical in position and normal at contour. Nipple areola complex, right side it was normal. There was no retraction, deviation, fissure, ulceration, eczema, or any of the skin changes were noted. On the other hand, on the left side, there was a change in the nipple areola complex. Nipple is drawn up and retracted with areolar size reduction, but there is no deviation, fissure, ulceration, or eczema. There was just inward retraction of the NAC. Breast surface, there was no visible swelling on either breast or neck. There was no scar, sinuses, dilated veins, pigmentations, redness, ulceration, or any puckering or any pudy orange changes. Inframammary region was also within normal limits. Axilla, supraclavicular region, infraclavicular region, and internal mammary region, there was no visible swelling. Both the arms were symmetrical in size and appearance with no signs of lymphedema. Now, on dynamic inspection, at rest, the left nipple was noted to be retracted. On leaning forward, both the breasts fell equally with no lag or asymmetry. On raising both the arms above the head, there was left nipple became flattened and drawn up medially with visible fullness in the upper half of the left breast. With hands pressed on the waist and pressing on the examiner's shoulder, then again this left NSC retraction became more evident. Now coming to the palpation. Again, before palpation, patient was explained regarding the procedure, and patient was palpated in a clockwise systemic fashion. First, the normal breast was palpated, then to the pathological breast was palpated. There was no abnormality that was detected in the right breast. Grade 2 ptosis was noted in both the breasts. Left breast, the temperature was equal in all the quadrants. No signs of inflammation was noted. Tenderness was absent in all the quadrants. At 12 o'clock position, to 10 o'clock to 12 o'clock position, 3 centimeters from the nipple areola complex, a 3 into 3 centimeter irregular surface, well-defined margin, and stony hard consistency, mass was detected, which was not fixed to the skin or underlying muscle, but it was fixed to the breast tissue. There was no associated skin changes. Regional lymph node Regional lymph nodes were palpated systematically, axillary chain and supraclavicular chain. There was no palpable lymphadenopathy. Now, she was also explained and examined per abdominally and per vaginally. Per abdomen, the abdomen was soft, non-tender, and non-distended. There was no skin changes, sinuses, or scars other than a well-healed infraumbilical tubectomy scar. There was no hepatosplenomegaly, and there was no free fluid. She is moderately built, so renal ballotability was not detected for her. Then, after again explaining and the need of per vaginal examination, she was examined per vaginally with per speculum, and the external genitalia was normal. The vaginal mucosa was healthy with no abnormal discharge or no bleeding. Cervix was healthy. The rectouterine pouch was also, there was no nodularity. Fornices were free, non-tender. No adnexal masses were felt. Coming to the systemic examination, the respiratory system, cardiovascular system, and central nervous system was examined. Along with that, musculoskeletal system. She does not have any complaint of any bony tenderness over the vertebral region or iliac blades or scapula. On respiratory system examination, the bilateral air entry was proper. Bilateral vesicular breath sounds were heard. Trachea was in the normal position. Cardiovascular system, we heard S1 and S2, and the apex bit was heard at fifth intercostal space, medial to the mid-clavicular line. Central nervous system examination, she was higher mental function was normal. Cranial nerves, all the cranial nerve functions and the motor functions and the sensory functions were intact. So, coming to the summary of my patient is a 50-year-old postmenopausal woman. She is a housewife from Hyderabad with maternal history of breast cancer at the age of 48 years old. Now presented to us with a painless, gradually progressing lump on the left breast for the last 5 months. On examination, there is a 3 into 3 centimeter hard, irregular lump in the upper quadrant of the left breast at 12 o'clock position, 3 centimeters away from the nipple areola complex, with no skin changes or no nipple discharge, with no significant axillary or supraclavicular lymph nodal swelling. All the other systemic examinations were normal. So my provisional diagnosis will be an left breast carcinoma, clinically staged as T2 N0 M0.
Good. Dr. Abhilas, your presentation was good, but need some clarification. So whenever you are presenting, don't write the name of the patient. Okay?
Okay,
Just
sir.
like Geeta Agrawal, just you can mention GA. Okay?
Okay.
So it
Okay.
should be, it's not mentioned. Even also during any reporting or when you are also producing any reports of the patient, you have to also um, hide that name of the patient. Okay? That's very
Okay.
important. So now you tell me, you are thinking that this is a case of carcinoma breast, isn't it?
Yes, sir.
50 years old, postmenopausal woman, and having lesion of 3 into 3 centimeter, but simultaneously, the patient is having nipple areola complex involvement on left side, isn't it?
Yes, sir.
But you have also mentioned here that this is clinically T2 N0 M0. Can you
Yes, sir.
justify this?
Sir, based on the patient's history, it was over the span of last 5 months. So the duration is insidious. All the benign causes usually are not within 5 months. And along with that, we have also seen that patient does not complain of any pain. Painless swellings are usually a red flag in oncology, and we can perceive them as malignancy. Other than that, sir, the patient's lump, when it was examined, it was stony hard in consistency, sir. That mostly aligns with malignant changes, sir. So that's why provisionally I have made the diagnosis as left breast carcinoma, sir.
Part fixity to the skin, and not if fixed to the chest wall, then it is malignant clinically.
Okay, sir.
If not, fixity to the skin or lymph node pulpit.
See, Abhilas, my
Yes,
question is in other way. You have
sir.
mentioned that there is involvement of the nipple areola complex.
Yes, sir.
Beside that, there is a lesion of 3 into 3 centimeter.
Yes, sir.
Okay. And here you have mentioned clinically it is T2. How to justify this?
Uh, Sir, there is no skin changes as such. The nipple retraction can be due to desmoplastic reactions of the ducts, sir. It can be fibrotic changes of the ducts that is pulling the nipple. There is no direct invasion of the skin, sir. So we are staging it as an T2, sir. If any satellite nodules,
Very good. So
ulcer.
point is that if there is any ulceration or satellite nodules, then we can stage it as it P4B.
Yes, sir.
But there is no ulceration or there is no satellite nodules. We have
Yes,
to stage it according to the primary tumor site.
yes,
Okay.
sir.
So for the clarification here, you have mentioned that this is a 50 years old postmenopausal woman.
Yes,
Okay.
sir.
Why you say that this is postmenopausal woman? What is the definition of postmenopausal status?
Sir, based on WHO and ACOG criteria, there has to be 12 months of amenorrhea, both without any pathological or physiological cause, or if she has undergone surgical menopause like bilateral salpingo-oophorectomy, and according to NCCN also, like if the patient's age is more than 60 years, then we can call the patient menopausal. These are the clinical criteria, sir. Other than that, we also have some lab criteria. Laboratory finding wise, the LH and the FSH levels will be high, sir, and the estradiol E2 levels will be low, sir. FSH levels more than 40 to 60, and
Very
estradiol
good. Okay.
levels.
Fine, fine. So now
Yes.
you can tell me that why you say that this is a case of carcinoma breast. Can it be anything else?
Sir, it can be as the NSC is involved, it can be an case of cystosarcoma phylloides, sir, or it can be an giant fibroadenoma, sir, or uh,
Okay. So how to distinguish these two?
sir, phylloids tumor is an fibroepithelial tumor, more behaves like an sarcoma. So there will be overlying skin changes, sir. There will be more stromal overgrowth, sir, and there will be some
Clinically, just tell me clinically.
uh,
Clinically.
clinically,
How
sir.
you say that this is a case of cystosarcoma phylloids based on what?
Sir, the PUD orange appearance will be more prominent, and we can see some leaf-like clefts will be there, sir. And age
If
will
like
be
left, that is not clinical findings.
okay, sir.
See, this also that may also confuse. Either
Oh,
the three possible provisional diagnosis here, either it is a case of fibroadenoma or it is a
okay, sir.
giant fibroadenoma and also cystosarcoma phylloides.
Will
Giant
okay.
fibroadenoma when the size is more than 5 centimeter, isn't it?
Yes, yes, sir.
And particularly that occurs in younger age.
Yes, sir.
So that is ruled out. So she is a lady of 50 years. So possibly it may be a cystosarcoma phylloides or it may be a case of carcinoma.
Yes, sir.
Okay. So now you tell me if you are thinking that this is a case of carcinoma breast,
Yes, sir.
how to confirm your diagnosis?
Sir, I would like to go for an ultrasound guided true cut biopsy from the lesion, sir. And opposite side breast also, I would like to get a mammogram done, sir, initially.
So my question, first listen the question.
Okay,
How
sir.
to confirm your diagnosis?
Sir,
So
with
confirm your diagnosis means it's a histopathological confirmation.
yes,
So
sir.
you have
Yes,
to go for the true cut biopsy,
yes, sir.
isn't it? Why
Yes, sir.
not FNAC?
Sir, FNAC is like it won't be able to differentiate between in situ cancers and invasive cancers, sir. And the sample that we will be getting from FNAC will be much less compared to an true cut biopsy, which can later be used for IHC markers, sir. And uh, FNAC is also more of like it is operator dependent, sir. So it is based on the experience of the radiologists also, sir.
Okay. So can we go for incisional biopsy?
Uh, Incisional biopsy, we can go, sir, but if the tumor is deep, sir, there will be while taking the incisional biopsy needle out, there might be some seeding, sir.
Okay. It's not needle knife. It's not needle. Okay.
Yes,
So
yes, sir.
what is the most common histopathological type that you come across?
Sir, invasive ductal cancers, sir.
Very good. So what is the site of origin of the invasive duct carcinoma?
Sir, that terminal TDLU, sir.
Okay, terminal ductal lobular unit,
Unit.
isn't it?
Yes,
What is
sir.
the most common site of the carcinoma breast? Most common site.
Sir, upper outer quadrant, sir.
Why? What is the possible explanation? Everybody said that it's at the upper outer aspect, but what is the possible explanation?
More breast tissue there, sir.
Very good, very good, very good. So there is more amount of breast tissue at the upper outer quadrant. Can you justify that? What do you mean by multicentricity versus multifocality?
Sir, multicentricity is when the multiple uh, lumps are there in various all the quadrants, sir, or different quadrants. Then we call multicentric, sir. Multifocal will be multiple lesions will be there in the but in the same quadrant, sir. Then we call it multicentric, sir.
That means it arises from same duct system.
Yes, sir.
But in case of multicentricity, it arises from the different ducts. Okay.
Yes, sir.
So in multifocal, we can say that that is local disease. And also if in multicentric, that we can say that it's a separate primary tumors. Okay.
Yes.
For
Yes.
which we may also go for the BCS, particularly in multifocal, but not in multicentric disease. Okay.
Yes. Yes,
Can
sir.
you highlight what do you mean by triple assessment?
So triple assessment means we'll clinically examine the patient and clinically stage. Along with that, we'll do imaging, sir, and then we have to get a tissue confirmation. All of them three combined is called triple investigation, sir.
Okay. Now you tell me what the role of mammography here
Sir, I
in
did
this
not.
case?
Sir, can you please repeat the question again, please, sir?
Is there any scope of mammography in this case?
Mammography, sir, we can do on the opposite breast, sir, and
Why not same breast?
same breast. I would like to get a as I will get a USG guided biopsy, sir. So we'll be doing USG.
No. Can anybody answer this question?
Yes,
If I
same
want
breast
to,
mammography is needed.
Yes,
pardon?
sir. Mammography is needed, sir,
Why?
Same breast.
to
Rule out any other quadrant lesion.
Very good. So we can also rule out the any possibility of the multifocal or multicentric lesion. And for the opposite breast also, to see is there any lesion in opposite side of the breast. Okay. So we can rule out the possibility of the which histopathology there is involvement of both the breast. Which
sir, lobular
histopathology type?
sarcoma, illobular
Very
sarcoma.
good. Very good. Now you tell me that this mammography, baseline mammography, has any bearing with our future treatment? Do we refer this baseline mammography for any further treatment
Uh,
in in respect to radiotherapy?
Sir, for boost planning.
Very good. For boost planning. What is BRADS?
Sir, BIRADS is breast imaging reporting and data system. This is
It was
the
developed by
ACR, sir. American
that is
College.
American College of Radiology.
Yes, sir.
Okay. So in which BRADS it is suspicious and also we have to go for needle biopsy.
Sir,
BRADS number, how much?
BIRADS 4, sir.
4. Very good. So what are the views in mammography that we usually take?
Sir, we take for screening mammography, we have MLO and CC views, sir. Medial lateral and craniocaudal views, sir. For diagnostic mammogram, we need extended views and other extra views will be taken, sir.
Like
One will be, sir, our extended magnified views will be there, sir.
say the common two views, craniocaudal and mediolateral.
Yes,
And
sir.
to include the axilla also, we have to go for mediolateral oblique view.
Yes,
Okay.
sir.
So what is the characteristic of mammography finding when we can suspect that yes, patient is possibly suffering from carcinoma breast?
Sir,
Can you
from
highlight that?
yes, sir. Sir,
Yes.
from shape wise, it will be an irregular shaped mass lesion. Along with that, there will be diffuse microcalcification that will be linear branching and
Okay.
very
Okay.
small microcalcification. Along with that, there can be, sir, architectural distortions also.
Very good. Very good. Can you tell me regarding the distribution of the microcalcification? There is some criteria where we can say that yes, patient is suffering from carcinoma breast. How
Sir,
many numbers, at what area, and what is their distribution?
So around in 1 centimeter area, if there are 5 or more microcalcifications,
Oh,
with 10 microcalcifications within 2 centimeters, then it is clustered and it is suspicious of malignancy, sir.
okay. So in this case, beside the true cut biopsy, what other investigation you want to do?
Sir, in this case, I would like to get a after true cut biopsy and histological confirmation and bilateral breast mammogram. I would like to do blood investigations for this patient, sir, which will include CBP, LFT, renal function tests, along with that a
Why?
basic.
Why you go for LFT?
Sir, abnormal liver function tests can determine any pre-existing liver
Okay.
disease.
Okay. Carry on. Carry on. Okay. Next.
And sir, other than that, we'll do an chest X-ray to rule out any lung lesion simultaneous, any lung metastasis is there or not, and
Oh,
ultrasound abdomen to rule out any liver metastasis, sir. And we'll also assess as the patient does not have any bony pain, but the lesion is 3 into 3 centimeters. We can get a bone scan also done to see if any bony lesions are there or not, sir.
is it mandatory? What the guideline says?
Sir,
What the guideline says? In T1, bone scan is necessary? T1
uh,
lesion?
T1 lesions, it won't be necessary, sir.
Answer is no.
Yes, sir.
In T2, because this is a T2 lesion.
Yes, sir.
So, what's the guideline says?
Stage 3 and stage 4 wise, it is mandatory, sir.
Yes, that's mandatory. But what about in stage 2?
Stage 2, if patient is having symptoms of bone pain, sir, or any bony point tenderness, then we can get a bone scan done, sir.
Very good. But there is no such symptoms in this patient. And
Yes, sir.
also, you have to also go for the serum ALP. Okay,
Yes,
fine.
sir.
So, it's not mandatory.
Yes, sir.
Beside that, any other test you want to do?
Sir, this patient does not have any clinically palpable nodes, but we still want to, before going for definitive treatment, we should get a USG of the axilla done to rule out any suspicious nodes, sir.
Okay, fine. Any further investigations? You have
Uh,
done the histopathology, but Simon, you have not covered that. Okay.
Sir,
So beside histopathology, what
Dr.
about other?
IHC.
yes, sir.
Yes.
IPC testing
So,
will be doing ER/PR status and KI HER2 status and KI67 status we would like to get, sir.
okay. And you have given the history, that family history of malignancy.
Sir, for that I will first counsel the patient. After pre-test counseling, I will ask the patient for BRCA1 or BRCA2 directed NGS, sir. Genetic testing, sir.
Okay. Do you think that there is any role of MRI in this case?
Sir, if in the mammogram, if we see diffuse multicentric calcifications, then we can get a MRI done. As this patient is also, if there is any suspicious, if there is any clinical and radiological discordance, then we can get an MRI done for this patient, sir.
Okay. So that's not as a routine procedure in this case.
Yes, sir.
Okay. So you mentioned that the regarding receptors. So what are the different receptors that we come across in breast?
Sir, estrogen receptor and progesterone receptors,
So
and
is it nuclear or the cytoplasm or the membrane receptors?
sir, estrogen receptor and progesterone receptors will be nuclear receptors, sir.
And HER2 neu?
HER2/neu is an EGFR variant, sir. So it will be in cytoplasmic or sorry, cell membrane receptor, sir.
Membrane receptors. So
Yes, sir.
what methods that we adapt to do the ERPR HER2 neu?
Sir, for ER and PR, we can do immunohistochemistry stain, sir. For HER2 also, we can do immunohistochemistry stain, sir. But if it is coming as 2 positive, then we should, or equivocal, then we can do an FISH, sir.
We have to confirm
Yes, sir.
by the FISH,
Yes, sir.
isn't it?
Yes, sir.
Okay. So taking these ERPR, HER2 neu and Ki67, can you classify the molecular subtypes of the breast cancer?
Yes, sir. There will be four subtypes, sir. Luminal A, luminal B, HER2 enriched, and basaloid types, sir. Luminal A will be ER positive, PR positive, HER2 neo negative, and low Ki67, sir. For luminal B, we have two options. It can be ER-PR positive and HER2 also positive with low Ki67, or it can be ER positive, PR positive, and high Ki67 with HER2 neo negative, sir. HER2 neo enriched is HER2 neo strongly positive. Basaloid is triple negative breast cancer, sir. All the three IHC markers will be negative, sir, for this patient.
So out of all these, best prognosis, which one have the best prognosis?
Luminal A has the best prognosis, sir.
And poor prognosis?
Triple negative breast cancer at basaloid will be having the worst prognosis, sir.
Beside that, do you know any molecular testing that is particularly in aged person and where we can also plan for the hormonal treatment only? Any other molecular testing?
Sir, for ERPR positive, HER2 neo negative cancers, we can go for Oncotype DX, sir, and Mammaprint. And for
Oncotype DX, how many genes?
sir, 21 genes, sir. 21 genes,
And
sir.
Mama print?
Sir, 70 genes, sir.
Anything device in India? Do
Sir,
you
we
know
have
what is the name of that?
can
Can
assist.
assist.
Can
Can
assist.
answer. Very good. Very good. So fine. So coming to this case, let us think that this patient has, you mentioned that this is C2, CT2, CN0 and M0.
Yes.
Okay. Why you say it is M0? Why not MX? Because you have not done all the investigation. Before the investigation, you have mentioned that this is CT2, CN0 and M0. Why not MX? Is it justified? Is it correct?
Sir, clinically, we have assessed the areas, so that's why we are mentioning it as an M0, sir.
You have assessed, but you have not find out, not confirmed. But can it be MX? No, you are correct. Okay.
Okay, sir.
Because in metastatic workup, even it has not been performed, do not write because latest AJCC, do not write MX. Instead, you should write clinically M0 if there is no meaningful evidence of metastatic disease that is appreciated clinically. Okay. So it's
Okay.
not to be MX, it should be M0.
Okay, sir.
Okay. So
Okay, sir.
based on this, let us think that on histopathology, are you having histopathology report of this patient?
No, sir.
No. Okay. Fine.
Actually,
So let us think that this is a case of infiltrating duct carcinoma.
okay, sir.
Okay. And patient having uh, triple negative.
Okay, sir.
Okay.
Okay,
Clear?
sir. Okay, sir.
So if you're going for the TNM grouping, okay. So
Okay, sir.
it comes in what type of breast cancer, whether it's early breast cancer or locally advanced breast cancer or metastatic breast cancer.
Sir, early breast cancer, sir.
So it comes in, this is T2, N0, M0. Okay. So
Yes,
if
sir.
this is T2, N0, M0 stage grouping, then what
Yes.
will be the stage of this disease?
Clinically, sir, it is
Stage 2A.
2A, sir.
Okay.
Okay, sir.
So it is early breast cancer.
Yes, sir.
Because early breast cancer, it is either stage 1 or 2A or 2B. Okay. And locally advanced, it is 3A, 3B, and 3C. Clear?
Yes, sir.
So it
Yes, sir.
comes in early breast cancer group.
Yes, sir.
Fine. So if the patient is having infiltrated duct carcinoma, triple negative early breast cancer of size 3 into 3 centimeter, you are on OPD and patient has come to you with this histopathology report. What will be your advice?
Sir, will explain the patient regarding the disease and then give the options of uh, breast conservative therapy. It can, which includes breast conservative surgery followed by chemotherapy and radiotherapy, sir. And we'll also explain the patient regarding like BCT is equivalent to our modified radical mastectomy at this point. And Also, genetic counseling also I will be doing for the patient, sir, because the patient has genetic history.
Okay. So you want to do the surgery first?
Yes, sir.
Yes. Fine. So if it is a triple negative, the recent concept that we have to also go for neoadjuvant chemotherapy
Yes.
if it is T2 and above. Okay.
Yes, sir.
So here we can also go for neoadjuvant chemotherapy.
Yes, sir.
However, you have decided for the breast conservative surgery, isn't it?
Yes.
So what is the difference between BCS versus BCT?
Sir, BCS is only breast conservative surgery that includes wide local excision with proper oncological margins and nodal management, plus minus nodal management. On the other hand, BCT includes adjuvant radiation also, sir.
Okay. So what are the contraindications for BCT?
Sir, there will be few absolute contraindications and there will be some relative contraindications, sir. If the patient is pregnant, if there is diffuse widespread microcalcification, if there is a
Wait.
yes,
Person pregnant irrespective of the trimester?
sir, if it is an very late third trimester, sir, then we can wait and wait for we can do breast conservative.
No. You are talking in a reverse way. See, first trimester, okay, we cannot consider for the CT
Yes,
and RT. We can also think for surgery, but
yes,
not all the trimesters. Okay, so first
yes,
trimester is a contraindication,
yes.
not the second and third trimester. Okay, then carry on.
Sir, if there is diffuse widespread microcalcification all around the breast, sir, that also becomes an contraindications of breast conservative surgery. Other than that, sir, if it is an multiple margins are coming positive again and again, that also becomes an contraindications for uh, BCS, sir. Other than that, multicentric diseases will also be an contraindication, sir. Some relative contraindications, like if there is any contraindication to radiotherapy, sir, that can be an contraindication for BCS. Other than that,
What is
if
that? What are those points? What are these criteria?
sir, if there is any connective tissue disorder, sir, like SLE and Sjogren's syndrome, for those things,
What will happen? What
uh,
will happen?
sir,
If
those
patient have any collagen vascular disease, but I want
yes,
to give the radiation,
yes,
what will happen?
the
Why it is
skin
a contraindication?
the skin reactions will be more, sir, and the
Good.
skin changes will be more for these patients. Sir.
So there is more incidence of fibrosis, and the main purpose is lost, that is cosmetic aspect. Okay.
Yes, sir. Yes, sir.
Beside that, any other points?
Uh, mm, sir, if the
Request history of chest irradiation.
Yes.
sir,
Previous history of irradiation.
yes, sir.
Okay. Anything else?
Axial telangiectasia.
No, that comes in that same group. Whatever the breast versus tumor ratio.
syndrome.
Sir. Yes, sir.
BRCA.
If there is a huge tumor
Yes.
compared to the breast, then we cannot go for BCS, sir. Breast tumor ratio is more, sir.
So what happens if it is small breast and big tumor? Then what is the issue?
Sir, even if we do BCS, sir, it is becoming more like
Request.
MRM only, sir. The cosmesis point is lost, sir.
And if it is a big breast and small tumor?
Sir, then we can remove it, sir, with proper margins, sir. Wide local excision will be done.
Is it the answer? Anyone of you can add any point to this?
Sir,
Sometimes also, yes,
reconstruction is difficult.
yes, placement of the breast for the radiation also sometimes difficult. Okay, very good. Now you tell me that is there any here the patient having N0 status? Okay,
Yes, sir.
so is there any role of sentinel lymph node biopsy here? Even
Yes,
also you have done ultrasound, it is N0 status. But is there any role of sentinel lymph node biopsy?
sir, for early breast cancer, we can go for clinically N0 axilla, we can go for sentinel lymph node biopsy, sir.
What are the methods that are usually adopted?
Sir, we can use blue dye, sir, that is isosulfan or methylene blue. Other than that, sir, we can use indocyanine green, sir. And then we can use technetium 99 radionucleotides followed by SPECT CT, sir, SPECT. And with this combined dual tracer technique is also there, sir.
Okay. So can you highlight that radionuclide technique? You told
Yes.
something SPECT.
Sir, we'll inject the technetium 99 around the tumors, and the technetium 99 is an gamma emitter, sir. That can be detected by a gamma camera or in a SPECT CT, so nuclear medicine department.
Gamma probe will detect, and also we can also see the reflection of the isotopes on the. Okay.
Yes.
Now you tell me, this patient you want to do for the BCS, isn't it? And BCS has also been done.
Yes, sir.
But it's for the extra additional point for the student also. Beside BCS, what other type of surgery being done in case of carcinoma breast?
Sir, we can go for modified radical mastectomy in this patient also.
So what's the difference between radical versus modified radical mastectomy? Which
Uh,
structures are removed and which structures are preserved?
Sir, modified radical mastectomy, pectoral, other than we have three modifications, sir. We have the Auchincloss modification where pectoralis minor is getting retracted, sir. Scanlon where pectoralis minor is only divided, sir, and Pattis modification where pectoralis minor is removed, sir.
Good. That is for the pectoralis minor.
Yes,
What
sir.
about pectoralis major? Where
Sir,
it is removed and where it is preserved?
sir, in radical mastectomy, pectoralis major minor both we are removing, sir. Halsted surgery, sir, and
Yes.
this modified pectoralis minor we are keeping in
In modified, pectoralis major
minor
are
both.
preserved.
Hmm.
Okay.
Yes,
And in radical mastectomy, pectoralis major is removed. Okay.
yes, yes, sir.
Now you tell me you are going for the BCS. So
Yes,
you
sir.
might have seen during simulation, some clips might have given at
Yes, sir.
the tumor bed.
Yes, sir.
How many clips are usually placed and where it is placed? And what is its importance for the radiation oncologist?
Sir, it is usually will be in 4 to 6 in number, sir. It will be on superior, inferior, medial, and lateral. Other than that, it can be in deep and superficial base of the tumor also. So for us, it is important for our boost volumes, sir. Whenever post breast
Okay,
radiation
okay,
planning.
okay.
Yes, sir.
So if you want to dissect the axilla, how many nodes at least has to be removed?
So 10 nodes minimum has to be done.
At least 10 nodes to be isolated.
Yes.
So this patient had undergone surgery and post of histopathology, it implied that having a lesion, let us think that 3 into 3 centimeter infantile duct carcinoma, no LVSI, no PNI, margin negative, no lymph node involvement, and also triple negative,
Yes.
isn't it? So
Yes.
what is your next plan?
So post surgery will finish 6 cycles of carboplatin and paclitaxel first, sir. Then after the completion of chemotherapy, we can will be radiating the patient's breast, sir. I would like to go for an 3D CRT as it is an left-sided breast cancer, sir. I would also like to add deep inspiratory breath holding,
So
sir.
you want to give the chemotherapy, isn't it?
Yes, sir. Yes, sir.
So you want to give taxane-based chemotherapy.
Yes, sir. Carboplatin and paclitaxel, sir. I would like to.
Okay, because this is BRCA mutated. If it is BRCA mutated, okay, because family history also there. So what are the other options commonly practiced?
Sir, can you
Triple
repeat?
negative platinum is also one of the absolute indications. Okay. Any other options? Hmm. Do you practice chemotherapy?
No, sir.
No.
No, sir.
You are posted in chemotherapy ward?
No, sir.
No.
No, sir.
Olaparib can be given.
Olaparib.
Adriamycin cyclophosphamide followed by 4 cycles of Taxol.
Adriamycin and
Taxane
Cyclophosphamide.
followed by AC.
okay.
ACT
Okay.
regimen.
Okay. So you can give 4 cycles of SC followed by 4 cycles of taxanes, or you can go for TC 6 cycles. So you are not being posted in chemotherapy unit.
No, sir.
Mhm. Because sometimes also the funny examiner may ask that
Okay, sir.
whether you have seen platinum or not. What is the color of doxorubicin, or what is the color of cyclophosphamide? How it is? What is the whether it is in vial or ampoule? Like that, the funny examiner may also can ask this question. Okay, so if you are going for the uh, chemotherapy,
Hmm.
okay, I think we can skip the chemotherapy because you are not practicing chemotherapy. Okay, fine. In this case, should we subject this patient for the adjuvant radiotherapy?
Yes, sir.
Okay. So now you tell me what are the indications of adjuvant radiotherapy in carcinoma of breast?
Sir, for all.
And the supporting evidence. Only 1 or 2 supporting evidence. Because
Okay,
you
sir.
are answering well, for that I'm asking.
Okay, sir. Sir, for all the breast conservative surgery patients, post-wide local excision and the surgical management, they should be undergoing radiotherapy, adjuvant radiotherapy, sir, because it is equivalent to, then it is becoming equivalent to MRM. We have the multiple trials proving that. The early breast cancer trial is group beta analysis has proven it, sir. And important trials will be our Milan 1 trial and URTC trials, sir. For any post-mastectomy cases, sir, any T3, T4 disease, meaning more than 5 centimeter size, sir, we can give them post-operative radiotherapy. Other than that, sir, any N2 status according to the EBCTG, it will be an indication for RT, sir. Right now, according to the UK-based Supremo trial, they are suggesting, sir, on N1 also we should give RT, sir, PMRT.
Okay.
Other
So
than
can you
sir,
highlight regarding fractionation schedule?
sir, for my patient, I would like to
What
go for.
fractionation that you follow in your center?
Sir, we are following moderately hypofractionated regimen, sir. 40.05 grain, 15 fractions, sir. Start B.
Okay. Start B trial.
Yes, sir.
Any other hypofractionation schedule?
Sir,
Moderate
Ontario,
hypofractionation.
sir, Ontario Clinical Oncology Group, Canada-based trial is there, sir. Based on that, 42.56 in 16 fraction is also an option, sir.
And what is the ultra hypofractionation schedule?
Fast and fast forward based trials are there, sir. 26 grain, 5 fractions we can give, sir, for early breast cancers.
Can you highlight a little regarding, because all the people are crazy for the fast forward trial? Okay.
Okay,
Have you
sir.
gone through this study?
Yes, sir.
So it is a phase 2 or phase 3 trial?
Phase 3, sir.
Phase 3.
Yes, sir.
And the comparator arms?
Sir, comparatively, arms was one is 27 in 5, sir. Another one is 40.05 in 15, sir, based on start B, sir.
And
Another one is 27 grain 5 fraction, sir.
so 40, 15, 27, 5, 26,
20.
5. Isn't it?
Yes,
So
sir.
what are the primary endpoint?
Sir, we were seeing ipsilateral breast tumor recurrence, sir, and along with that cosmetic
So
outcome.
it's a local tumor control.
Yes, sir. Local.
Isn't it?
Yes, sir.
So what are the conclusion?
Sir, 26 grain 5 fraction is non-inferior to 40 grain 5 fractions. Even 27 grain 5 fraction also achieves.
Okay. Why we consider for this hyperfractional schedule in carcinoma breast?
Sir, breast tumor has an alpha by beta of 3 or very less. So they act like late reacting tissues, sir. So to control
Okay.
them,
So what other sites also having the alpha by beta ratio is low?
sir, carcinoma prostate, sir, it has an
What is
alpha,
the alpha by beta ratio in C prostate?
sir, 1.5 to 1.8, sir.
Very good. Very good. Okay. So absolutely correct. So you mentioned that this is a left side carcinoma breast, isn't it?
Yes, sir, yes.
So you want to go for DIBH.
Yes, sir.
What is the advantage?
Sir, with deep inspiratory breath holding, we are gating our radiation beam, and also the heart is pushed downwards, sir. So the mean heart dose is reduced, sir. Along
How
with,
much? How much? Mean
sir,
heart dose reduced how much? in a tune of 50 to 60%. That's from 4 to 6 grade to it comes out to 1 to 2 grade,
Yes, sir.
isn't it?
Yes, sir.
And what about the lungs?
Lungs doses are also reduced, sir.
Okay, fine. So after can you highlight the radiation portal?
Sir, can you repeat the question again, sir?
Radiation portal, defining the radiation portal, simulation and also define the radiation portal.
Sir. Sir, our patient will simulate in supine position within breastbone, sir. And I would like to get a scan from the.
Yes.
Sir, 1 minute. I would like to get a scan from.
Any issue?
Hello, sir.
You
Can you
have
hear?
to. Yeah.
Hello,
Hello.
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 Sir, am I audible?
Yeah.
Sir?
Yeah, you are audible. Continue.
Sound is there is some problem with the sound, sir. It's not coming properly. Hello,
Hello. Hello.
hello.
Yeah, you can continue.
Sir, I would like to I would like to simulate my patient in supine position, sir. Hands by the
Hmm.
side, sorry, arms above, sir, with breastbone, sir. Along
Hmm.
with, I will take an planning CT scan of 5 millimeters, sir, and I will non-contrast CT, sir, and I will also mark the scar, sir. 2 centimeter around the BCS surgical scar. I will mark, sir, and then I will be giving 3D CRT to the patient, sir, after contouring. And my portals will be, sir, for this patient, as the none of
Your simulation field portal extends from what to what?
sir, for this patient, we are not planning any regional nodal irradiation, sir. So it should be from our
What is
sternoclavicular
the cranial extension and what is the caudal extension?
joint and 2 centimeter below the palpable breast tissue, sir. Superior and inferior, sir.
Is it correct? You have to go from the cricket up to the 5 centimeter below the clinically marked info portal. Okay? Because you have to include the whole of the long fields. Fine. Carry on.
Okay, sir.
So what is your medial border?
The medial border will be for this patient midline, sir.
Midline? Or should we cross the midline?
Sir, midline, sir.
Okay. So it's at the edge of the sternum and usually should not cross the midline. What is the lateral border?
Lateral border will be, sir, mid axillary line, sir.
Okay. And what is the cranial?
Cranial border will be the cranial border of sternoclavicular joint, sir.
Head of the clavicle. Okay, sternum. Fine. Now you tell me, is there any scope of the boosting to the tumor bed?
Mm, For our patient, yes, sir. We
You want to
can.
boost the lumpectomy cavity?
Yes, sir.
Yes. How to locate the lumpectomy cavity?
Sir, we'll have the surgical clips, sir. Based on that, we can give our boost volume, sir.
What is the drawback of surgical clip?
Sir, they can dislodge and they can
Okay. Then what are the other methods?
around the scars at 2 centimeters circumferential margins will draw and we can draw and boost.
No. This is not absolutely. Any other methods?
There is any
Check
serum
the
collection around?
previous
Yes.
APB.
Yes.
check the previous imaging, initial imaging.
Okay. Anything else?
There is any seroma collection or anything we can identify?
Very good. Seroma cavity that can be detected by either ultrasound or
Yes,
also the CT, what you are doing. Okay. Now, if you want to locate the lumpectomy cavity,
Yes, sir.
what are the techniques? by which we can also irradiate the lumpectomy cavity. What are the methods? Commonly practiced
Sir, external beam boost we can give with photons and
external beam by photon or electron.
photon or electron, sir. We can give brachytherapy boost in the area, sir.
Where? Brachytherapy, where?
Lumpectomy area, sir, within mammocyte.
Let us think that I am giving one of the example.
Okay, sir.
The lesion is present 6 centimeter below the surface.
Okay, sir.
Okay.
Okay, sir.
Can you opt for the electron beam?
No, sir.
Why?
Sir, electrons are usually they will be there.
How to calculate the energy?
Sir, we will see the
How to
R90.
calculate the MeV? It is 6
R90,
centimeter.
R90 will see, sir. R90 is usually E by 3.2, sir. Based on that, we'll calculate the depth, sir.
See, simple में था तो अभी कितना आएगा?
Hello.
हाँ, how much MeV will be there if you will calculate?
So 18 MeV around is coming, sir. 18 to 20.
18. More. See, if it is 6 centimeter deep, you have to give 0.5 margin also. 6.5 into 3. Okay. So
Yes,
it
sir.
comes around 19.5. But maximum we are having 18 MeV.
Yes, sir.
Okay. There we can also think for the implant. Okay.
Yes, sir. Yes.
Which type of patient are mostly benefited with the boosting to the lumpectomy cavity?
Sir, if the patient is young, sir, and if higher grade is there, sir, we have Jekestro boost criteria for that, sir. Grade 3 patients, sir. Grade 3 patients, if the patient's age is less than 50, for those patients, we should ideally boost them, sir.
Okay, fine.
LVSA positive, sir.
Yeah, mostly the young, LVS is also correct. Mostly the young person less than 40 years. Okay. Do you know anything about APBI?
Yes, sir. It is on form of,
What are the criteria for the APBI?
sir, for APBI, we have Jekestro criteria, sir, and also we have Astro APBI criteria, sir.
What should be the age of the patient?
Uh, Based on Astro 2016, sir, suitable patients will be more than 50 years, sir.
Okay. Tumor size?
Uh, Tumor size should be less than 2 centimeters, sir.
2 to 3 centimeter
Okay, sir.
maximum.
Yes, sir.
And what are the nodal status?
Nodes ideally should be negative, sir.
Negative. And
In
histopathology?
histopathology was, sir, there should not be any BRCA genetic mutation, sir. We can take any grade. ERPR should be positive, sir, and HER2 should be negative, and there should not be any extensive intraductal component, sir.
What are the methods that are being adopted for APBI?
Sir, we can give interstitial brachytherapy, sir. Then we can give hybrid balloon applicators like Mammocyte and Struve, sir. And then we can also give external beam radiotherapy boosts, sir, like IPBI with using external beam radiotherapy, sir.
Okay. So you are on OPD.
Yes, sir.
And patient comes to you for regular follow-up. What is your follow-up schedule?
Sir, for the first year, every 3 monthly we'll follow the patient. From second year onwards, it is 6 monthly, sir. And from third year onwards, it is yearly, sir.
Okay, so you are little. This is your institution protocol?
Yes, sir.
Okay. What late complication that we come across when you give radiation to the patient?
Sir, we can end up seeing cardiac complications, sir. And also because the lung is coming in the field, so we can expect pulmonary changes.
First you tell the common complications. Common that we come across. How many
sir.
cardiac complications that you have seen?
No, sir. Skin changes, sir. Skin fibrosis.
Anything else?
Lymphedema.
Yes. So there is more chances of lymphedema,
Yes, sir.
isn't it?
Yes.
Anything else?
Hypothermia.
Thyroid.
Good. So, Dr. Abhilash,
Sir,
it's a nice presentation,
thank you, sir.
and you need little modification of your presentation
Okay, sir.
because few questions may be also discussed with the regarding your presentation, because this is not a direct case presentation,
Okay,
and
sir.
this is in a PPT, so it's not possible to cover all the points,
Okay, sir.
because during your presentation, the examiner may also ask few questions
Okay, sir.
regarding marital history, regarding the obstetric history, family history. So these also question may be asked.
Okay,
Okay.
sir.
Otherwise, thank you, Abhilash. It's an excellent presentation. Dr.
Thank you, sir.
Kanu, I
Yes,
think
sir.
I covered it in time.
Yes, sir. Yes, sir.
Yeah,
Thank you.
send me only
Thank
1
you.
hour.
Thank you, sir. Thank you for your time. And after your busy schedule, you came and guided our students. It is very nice of you.
Yeah, Kanu, can I
Sir.
take 2 minutes for the students?
Sir, no problem.
Mm, I like to share the presentation, and just I'm sharing it.
Hello, sir.
Dr.
Sir,
Kanu, just you ask him to, yeah, that his PPT is open, so you can stop sharing.
okay. Dr. Abhilash. Dr. Abhilash,
Yes, sir.
please just stop sharing from your side.
Okay, sir. I will stop, sir.
Okay, sir. He stopped. You can share your slide, sir.
Okay. Is it visual now?
Sir, it is not in the slideshow mode.
Yeah, I'm bringing it to how to do that?
Go, sir. Go down. There is that umbrella type icon is there on the lower part.
Oh yeah, yeah. So few points just I'm just covering for the examinee, because that is very important. Let us think that they have not come prepared. Okay. So what to do? So for management cancer, the students please follow that whenever there is a question of the management of cancer, so there don't write only treatment. So management comes diagnosis, treatment, no, diagnosis, staging, treatment, and follow-up. So 4 points that has to be covered, at least. And you have not come prepared. Okay. So if a question comes, like, let us think that carcinoma, breast, T2, N0, M0, then how to answer? So few points for the diagnosis, you have to take few points like clinical diagnosis, note it down, biochemical diagnosis, radiological, endoscopic, immunohistochemistry, graphical and therapeutic. So here everything comes. clinical, biochemical, radiological, endoscopic, immunohistochemistry, graphical, and therapeutic. Okay. So on clinical diagnosis, either there may be a ulcer, or there may be a swelling, or there may be indirect effect, like the carcinoma esophagus producing obstruction, or there may be regional spread of the disease for which there is symptoms, or there may be metastatic disease, or there may be paraneoplastic syndrome. So from the clinical point of view, we can cover all the either ulcer or a tumor or a metastatic region or metastatic or the paraneoplastic syndromes. Like that few pictures you can see here. This is a xeroderma pigmentosa with multiple cutaneous malignancy. This patient is more prone for the multiple cutaneous malignancy, like same patient, either squamous cell carcinoma, basal cell carcinoma, melanoma. The second picture you can see here, this is a tuberous sclerosis, is subependymal giant cell astrocytoma. And this is another case of tuberous sclerosis with also, that is the angiomyolipoma of both the kidney. And this is a multiple neurofibromatosis with neurofibrosarcoma, that NF1. And NF2, you can see a bilateral acoustic tumor, and also same patient having the osteosarcoma. And this is also the extrophy of the urinary bladder with the carcinoma over the bladder. And this is bone scar over which the patient has developed the carcinoma. So that is for the clinical diagnosis. Radiological diagnosis broadly divides into fluoroscopy, teleradiography, and modern imaging like CT, MRI, PET, and everything. Okay, that is for the radiological diagnosis. Then also bone scan, PET. So that comes under the radiological diagnosis. And this is the most important, the confirmatory modality of the diagnosis, that is the biopsy or the histopathology. There the different types comes like aspiration or incisional, excisional, needle biopsy, or different image guided procedures. And these are the different IC markers for the different tumors that we have to remember. So the final diagnosis comes only two things, the anatomical and pathological. Anatomical means that is anatomical side is breast, and pathological is the carcinoma. So based on all these points, then you can come to the final diagnosis. Then the staging, as usual, I'm just skipping this slide. And for treatment purposes in oncology practice, it based on surgery, radiotherapy, chemotherapy, targeted therapy, hormone therapy, immunotherapy, and for palliative purposes, laser and photodynamic therapy. So at least you have to remember the diagnosis, staging, and treatment. These 3 points or 3 slides is very important. Even also you are not prepared. If you can follow this, you can also answer the questions jolly well. Okay. So thank you. Thank you once again.
Thank you, sir.
Thank you, sir. Thank you.
Over to Kanu.
Thank you, sir. So next topic will be by Dr. Dona. So he and Dr. Parthasarathi Bhattacharya. He is very much interested in brachytherapy, and he will present the brachytherapy instruments, and Dr. Dona will answer the questions. And in the meantime, as I requested before, if you know anything, just to type it. At the end of the session, we will answer your questions. Dr. Dona, over to you. Dr. Bhattacharya, sir, over to you.
Yeah, please, we'll start sharing our screen.
Okay, okay.
Bhattacharya sir, इधर पूछ रहे हैं ना? You come to my or you जैसे screen share में नहीं हो रहा है? उससे जो सर हाँ
सामने एक्सिट किए सर
देखो From here you can do. There is a board.
सर कानू बोल रहा हूँ, सेनापति सर। हाँ हाँ
Now it is given. Now it is given.
नेक्स्ट बेंच करो।
So video sound. Yeah, is visible.
Yes, sir.
Yeah. Okay. So today we'll be discussing about 20 OSCEs. Okay. So I think 19 OSCEs are there. So it will be about 2 to 3 minutes for each OSCE, and I will try to finish by 1 hour. In between, if any questions are there, you can write in the chat box, or you can ask during the discussion also. So I'll ask Dr. Donor to proceed with the presentation.
You have to ask questions.
Is it visible?
Yes, sir. Visible.
So this slide shows us 4 applicators. So it is numbered and labeled as A, B, C, and D. So we'll be discussing individually each applicator. First of all, tell us about the applicator A.
Applicator A is flexure suit applicator. It flexure suit applicator for intercavitary radiotherapy.
In the Fletcher suit applicator, posteriorly you are seeing something. What is that?
Posteriorly, we have one.
This one.
This one.
What is that?
So it's rectal spacer.
So it's a rectal spacer. It helps in spacing the removing the rectum from the field of
radiation.
Okay. So what is the applicator B?
Applicator B is Vienna applicator for hybrid brachytherapy with paracervical needles. Needles can be inserted with this.
So we'll be going into details of those at a later time. So what is C and D?
C is Utrecht and D is tulip applicator for. These are both for hybrid brachytherapy.
So what is the use of what is the additional use of using B, C, or D if you have only intracavitary other than intracavitary applicators?
This will give